Aggie, thank you so much for inviting me to talk today. It's really an honor to have gotten to know you better over the last 7 months and to be part of the spectacular Pancreatic Cancer Research Center at UCLA. I'd like to talk to you this afternoon, briefly about a new type of therapy in which you can target let's say, a bad protein in the cancer, a master switch, and shut it off. And so that's what I'm working with a company, so I do need to say that I have a conflict of interest, that I'm a consultant for Gradalis. And this is in no way a bad thing. It's, the work never would have come out of my laboratory until I met the man who runs the company. His name is John Neumanitis. He's a medical oncologist that feels that really standard chemotherapy is not having the effect it should, so he's after new therapeutics to have more targeted therapy that would be effective. And he was very interested in the target that we identified in my lab. So I'll go over that briefly. As a surgeon, the pancreatic duodenectomy is really the only chance of cure at this point. And we have several of the best pancreatic surgeons in the world here with Dr. Reber and Dr. Hines, Dr. Donahue. It was first published by Alan Oldfather Whipple in 1935, and he actually did the operation in front of like an amphitheater, as if you would be sitting there watching. And the mortality was 33% in the first 27 patients. But when you think that he did this in 37 patients before blood transfusions and antibiotics, it really was a major tour de force. Over the last 70 years, it's now become a very safe and effective treatment for pancreatic cancer. And so for those of you, this shows you the Whipple. You go in and detach the stomach, you detach the bile duct, and detach the pancreas. Oh, it makes it so tricky, or all the major blood vessels going up to the liver is sitting right underneath the neck of the pancreas. And there's the tumor and the specimen. And then that usually takes anywhere from 2 to 4 hours. And then after that, you have to reconstruct the pancreas, the bile duct, and the stomach with a piece of intestine. And so it's a very safe and effective operation. As I said, UCLA has one of the best programs for this surgery in the world. If you look at a meta-analysis in which roughly 10,000 patients underwent a Whipple procedure, you can see that the 5-year survival is better than if they were not resectable. And so in the small percent of the patients that can have surgery, you have a 5-year survival averaging about 25%. For those that can't have the Whipple surgery, it's kind of a dismal 5-year survival. And so the question that we need for both of this, as a surgeon, what I would like for the patients I care for is, could we somehow improve that survival by coming up with more effective therapies? So now I'm going to spend a little bit of time talking about a surgeon's viewpoint on personalized medicine and genomics. So I'm trying to keep this simple. The Human Department of Health and Human Services gave us a mandate. This was in 2007, that they wanted to be the right treatment at the right time for each individual patient. What you just heard from Dr. Simeone's outstanding talk is that if the patient's tumor doesn't have the correct signature, they may not respond to the therapy we're giving them, and that the idea is we should know exactly what that signature is so we can apply the right therapy. So we've had a couple symposiums. I've been working on this for about 8 years with Dr. Gibbs, who's one of the world leaders in genomics. And so personalized medicine is the use of genomic information to optimize the care of our patients. Now, if we've been on Earth walking upright for 7 million years, it's only been the last 150 to 160 years that we even begin to understand about DNA and genomics. So Gregor Mendel was a monk who came from a farming family, and he did 30,000 pea plant experiments and figured out the concepts of Mendelian genetics. He wrote a paper, published it, but it wasn't recognized till about 50 years later when some scientists figured the same thing out. They found his paper and gave him credit for Mendelian genetics. About the same time, these are in the late 1860s, a Swiss doctor named Johannes Miescher was dealing with pus and found a very stringy material in it, and that was the discovery of DNA. If you flash 50 years forward, a group of scientists in England were busy trying to figure out the structure of DNA. And so this is James Watson, is on your left. As a young man, I want you to remember that picture because I'm going to show you a picture of him at age 79. And he was working with Crick, and they came up with the structure of DNA. And this is Wilkes and Rosalind Franklin. There's an interesting story about Rosalind Franklin. She did the X-ray crystallography, and it showed that it was a spiral going up, which enabled Watson and Crick to come up with the structure. She almost certainly, I've researched the subject, she almost certainly would have been given the Nobel Prize, but she died of ovarian cancer, and they don't award the Nobel Prize posthumously. Now, we flash forward another 30 or 40 years, and we have the idea of single candidate genes as targets. So we've all heard, in fact, we heard about it this morning with a great lecture, BRCA1 by Mary Claire King in 1990. Our own Dennis Slayman, who's at UCLA, came up with HER2/neu as a target and developed a monoclonal antibody, Herceptin, which is actually in clinical use now. That's an incredible discovery from UCLA. And then tyrosine kinase inhibitors like Gleevec by Nicholas Lydon. So you have the idea of single genes, that if we can target those genes, we may have effective therapies. Now you flash forward to 2000, and you have the completion of the Human Genome Project. And what the Human Genome Project was, 50 patients pooled their DNA. They were from Buffalo, New York. And 10 centers around the world spent 10 years deciphering the human genome. And it's one of the greatest accomplishments in the history of humanity. This is only 12 years ago. Now, that project cost $3 billion. We then flash forward 7 years, just 7 more years, and Dr. Gibbs in the Human Genome Sequencing Center in Houston sequenced Dr. James Watson's DNA. So the founder of 454 sequencing technology, Jonathan Rothberg, asked Dr. Gibbs, we should do our first human, who should it be? And Dr. Gibbs said, James Watson, of course. So he called Dr. Watson right then and there, and Dr. Watson said, sure, I'll do it. And when they asked, why did you volunteer? He said, because I never thought they'd be able to do it. So within 2 weeks, they were able to sequence his entire DNA. And that represents 6 billion base pairs, and it cost $1 million. Now, I know that sounds like a lot of money, but think that the human genome took 10 years to do, and it cost $6 billion. So this is a 10,000-fold increase in speed of sequencing and a 10,000-fold decrease in cost. So what's happening, what we're seeing in our generation right now is an exponential advance in sequencing. It is now down to about a few $1,000s to sequence any one of our DNA, and we can do it in a few days. Now, then you say, okay, well, so what? So then you go to this paper, and on your left is Richard Gibbs, who's from Australia. He's a very humble scientist, and he's one of the world leaders in this technology. And he took one of his partners, Jim Lupsky, and Jim's entire family, including Jim, have a disease called Charcot-Marie-Tooth neuropathy. They sequenced Jim's DNA as well as his family, and they actually found the disease gene, the SH3-TC2 gene. So now this represents yet another advance, that any one of us, we could have our genome sequencing, and now we can find the disease gene causing the disease. That's an incredible advance. So then someone might say, well, so what? So now we go to the holy grail of what to do. And once again, this is Dr. Gibbs's study. And it was published in 2011. So what he did is it took 2 twins that had dopa-responsive dystonia that were not responding to the dopamine agonists. Now, in this disease, everyone thinks that they have a mutation in the dopamine receptor. They sequenced their entire DNA, and they found out that they had a mutation in the serotonin receptor. Therefore, they added the serotonin agonist, and the twins, the 14-year-old twins, were essentially cured of their disease. So now you have doing the entire sequencing, finding the disease gene, and then treating appropriately, and that's personalized medicine. I believe this is really the first example of personalized medicine where they did the entire genome. So if we summarize, this was at one of our symposiums. There was a great edition of Nature back in 2010, and Francis Collins, who was in charge of the Human Genome Project, said that the progress of sequencing is exponential, as I've described. However, it is fair to say that the Human Genome Project has not yet directly affected the health care of most individuals. And as a healthcare provider, my colleagues that are in the room, and I know the Hirschberg Foundation, want us to move this technology forward so that we can affect the health care of most individuals by studying the human genome. I know it's going to happen probably within 5 or 10 years. So in coming back to UCLA in July, I wanted to implement a personalized medicine program in the school. And so as a surgeon, I try to think of a simple way that we could start with this program. And so I broke it down in type 1, type 2, and type 3. So type 1 would be the use of single gene mutations that are already in practice, that we already use, and I'll give you a couple examples. And I met with Richard Gibbs on last Thursday, and he came up with the term actionable genomics. So that if we were to measure your genome, which ones could we take action on and provide you with better care? Type 2 are the ones that we're studying in the laboratory, and I'll show you some of my own research on that. And type 3 is what you just saw in the Bainbridge twins, where we would do the entire genome, find the disease gene, and treat the patient accordingly. Now, we're starting with a small portfolio of these type 1, the actionable genomics, and we're building the portfolio. I'm proud to say that when I came here in July, we had about 8 on the list, and now we're up to 175, just by studying the internet and using a collective intellect approach. So I'm really excited that this is happening at UCLA right now. So here's a couple examples of the type 1. BRCA1, if the person is unlucky to have that mutation, we know there's an 86% chance of breast cancer. And so what we can do is either do close observation in a clinical trial, or we can offer them bilateral skin-sparing mastectomies with immediate reconstruction. So once again, that genomic defect is guiding choice of care by the physicians. Here's another one. You have the E-cadherin gene. When the person has that mutation, there's a 60% chance of getting gastric cancer. So my partner, Dr. David Chen, is actually performing laparoscopic total gastrectomies, and he's found a family that, like a lot of the people in the family have this gene mutation, and one by one they're having laparoscopic total gastrectomies to hopefully prevent them getting gastric cancer, which is really another incurable cancer. Okay, so the gene that I'm interested in is called PDX1, which is pancreatic and duodenal homeobox type 1. And what it's well known for, it's a pancreatic embryologic transcription factor. So Diane Simeone told you about Notch1 and Sonic Hedgehog. Well, this is yet another embryologic transcription factor. And in adults, what it does is it regulates insulin in your beta cells. So when I was at UCLA from 1989 to 1995, I was working with the late John Walsh, and we were trying to study insulin secretion, which is kind of an odd thing for a surgeon to work on. And we found out that it was discovered, not in our lab, that there were 5 receptors. And so we began to get interested in which receptors were regulating insulin, right? So what we did in my lab is we cloned somatostatin receptor 5 in a mouse, and then what we did is we knocked it out in a mouse. And this was in the days when a knockout, cloning the gene took 1 year, and making the knockout mouse took 3 years. and an incredible amount of money. That all can be done within a matter of weeks now. And so it was from this mouse that we think we have found the master switch to cancer. And so I'll show you how that happened. We perfused the mouse pancreas. In yellow is a normal mouse, a wild-type mouse, and you can see the insulin. When we give it glucose, the insulin goes here. And when you knock out the somatostatin receptor 5, you have a marked increase in insulin, goes way, way up. And so we were all excited that insulin was increased. Now, the regulator of insulin is PDX1. So what we did is we stained the mouse islet for PDX1. Here's the wild type. And you can see that the somatostatin receptor 5 knockout mouse had a marked increase in not only PDX1, but also in insulin. And then what we observed is the islet started to grow and became hyperplastic. So at that point, we started asking the question, could PDX1 be regulating hyperplasia and growth? And that's how we came on to PDX1. So we then took some human samples. As surgeons, one of our, I'd say, one of our major advantages that we have access to the diseased tissues. So we took benign pancreas, and you can see how PDX1 is just barely regulating, it's barely being expressed. When you look at human tumors, it's markedly overexpressed, and then it's really overexpressed in metastatic disease. We studied 80 pancreatic cancers that we had procured, and on the right, it shows that in every single cancer, PDX1 is markedly overexpressed. These come from UCLA. These are another form of pancreatic cancer called neuroendocrine tumors, and you can see in every slide that we've looked at, PDX1 is markedly overexpressed in these tumors. We then went back to the laboratory and started putting PDX1, and these are human pancreatic ductal epithelial cells. So these cells are benign cells. And you can see on the left panel, when you put PDX1, you get a nice significant increase in cell proliferation and an significant increase in cell invasion. Then what we did is we knocked it down using shRNA, and that's the therapy I'm going to tell you about. So this is the first time that we're starting to see that PDX1 is a master switch to turn on human pancreatic cancer, and that we can knock it down using shRNA therapy. So then what we did is we put PDX1 in human embryonic kidney cells, which are benign cells that are like a workhorse. When we put the cells in there, we implanted those cells in mice, and you could see that the cells with an empty vector had almost no tumor growth at all. The tumors with PDX1 had a really nice tumor response. When we put them inside human pancreatic cancer with low PDX1 expression, this was the tumor size. When you put PDX1 in those human pancreatic cancers, you get a nice large tumor in mice. So now we're starting to see this is the first evidence that when you put PDX1 in these cells, you start to get really increased tumor volume in SCID mice. We then looked at the mechanism of how it might work, and you heard some of this mechanism talk this morning by the wonderful talks. We can see that the cell cycle proteins, cyclin E, CDK2 are turned on, and the tumor suppressor genes are turned off in these mice, P53, P27, and P21. So we see a disruption of the cell cycle proteins by adding PDX1 into these tumors. Now, we took human pancreatic cancer cells. So PANC1 has very high expression, and we knocked down PDX1 by using shRNA, and you can see PDX1 is knocked down in those cells. MIAPACA2 has a much lower PDX1 level, but we still got excellent knockdown by our knockdown therapy. We had a medical student who is now a surgical resident here at UCLA, took our data before and after knockdown using microarray chips, and plugged it into a computer and came up with a signaling pathway. Now, this slide would have taken, in the old days, would have taken, probably years to develop, and the medical student was able to do this within about a week. And so we could see that when we knock down PDX1, we increase apoptosis of these human pancreatic cancer cells. We decrease proliferation, we decrease invasion, and we decrease angiogenesis. So you could see that by harvesting someone's tumors and running a microarray, we might be able to find that we'd have to have targeted therapy for a number of pathways to have effective therapy. So to summarize this part of the talk, we believe that we have discovered a new oncogene for pancreatic cancer, PDX1. We've shown that it regulates proliferation, it regulates invasion, it causes tumor growth in mice, and that it's overexpressed in almost all pancreatic cancers that we've studied. So at this point, I was fortunate enough 2 years ago to meet John Neimanitis in Gridalis, and he was very interested in our work on PDX1. What they've done is they've developed a new platform for a new type of therapy called RNAi therapy, and that stands for RNA inhibition. And by using this type of therapy, we could actually begin, we hope to begin to target individual genes within the cancer cell and create targeted therapy. So their platform is bifunctional shRNA. We put our PDX1 formula into their vector. They deliver it by liposomes as opposed to viruses. We do not want to use viruses. We're using liposome delivery. We want to give intravenous therapy over and over again. So we developed the vector with Gridalis, which are the companies in Dallas, Texas, and then we did all the efficacy testing in our laboratory during 2010 and 2011. The way the therapy works is you first give the liposome RNAi therapy. It drops into the cells. Obviously, it will only work in cells that express PDX1. And it's bifunctional because it activates two pathways. So it activates the RISC-induced silencing complex. And on your left, that RISC lands on the open reading frame and cleaves the RNA. On the right, it causes translational repression or P-body sequestration. So you have two functions of the RNA inhibition targeting PDX1 within the cells. And we've shown that it lasts longer and it's more powerful effect because there are two effects in one. So what we did is we did an experiment where we compared the bifunctional to our regular shRNA, and you can see that the bifunctional had a more powerful effect on inhibiting cell proliferation in these cells. In this, at the high dose, we saw no difference, but certainly a marked difference from the control empty vector. So we're excited that the bifunctional looks like it's having a more powerful effect in vitro. We then, and of course, we did all cell cycle work as well. We then put human pancreatic cancer cells in SCID mice. This is a model that we've been working with for about 12 years. If you put these cells intraperitoneally in SCID mice, the mice that have no treatment, their entire abdomen becomes filled with human pancreatic cancer over a period of several months. We then gave the treatment, which is liposomal, bifunctional, PDX1 shRNA. We gave it intravenously by tail vein injections, and we gave them 3 cycles. Very important concept, that multiple cycles will be needed to be effective. So this shows you in the untreated group, the abdomen was completely filled with tumor, about 1,400 cubic millimeters. The control vector had no effect on it, but when we gave the bifunctional shRNA, the tumors were almost completely ablated in the mice. Once again, this is intravenous treatment of metastatic human pancreatic cancer in SCID mice. We also saw that survival was markedly improved in the treated mice. And these step downs are from mice that were sacrificed so we could study the tumor during the treatment. And this is the untreated mice. So we had a nice improvement in survival with our bifunctional shRNA for PDX1. So to summarize, and this is the end of the talk, we have identified a new target for PDX1. We believe it's a master switch that if we can turn it off, the cancers will stop growing. We've developed IV bifunctional RNAi to PDX1. We've shown that it's effective therapy for human pancreatic cancers in mice. The company has now produced the human-grade quality therapy, and we have taken that and we're testing it in pig models at Texas A&M. We hope that we will be given a phase 1 clinical trial in 2012. We actually had permission to try it in the first person, and the day that we got the permission, the patient died of pancreatic cancer. We then, on that same day, had a 28-year-old woman appear with metastatic pancreatic cancer, and she's 28 and has 2 little kids that are 4 and 6. We asked the FDA, this was Christmas time, we asked them, could we please get permission to treat her, and they said no. So we were kind of disappointed in that, and I'd like to point out that the Hirschberg Foundation was able, with another foundation, to give the family Christmas gifts because they ran out of money using gemcitabine chemotherapy. So it was really nice for what you all did for this young lady and her family. And we're still saying a prayer that we'll be allowed to treat her if she can survive, and we hope we can get done with the pig studies quickly enough to start a phase 1 clinical trial this year. Once again, it's been an honor. Thank you for being here. Let me talk. I'd be remiss if I didn't recognize a large group of MDs, PhDs, medical students, residents who all worked on this project over the last 12 years. I'd like to thank them for being involved in this. And so we hope that the RNAi targeted therapy will be effective, at which point we can then start targeting any protein that we think is important. Thank you.